Good morning, everybody, and welcome to the first of our learning summits. I love that word, learning. So we're hoping the outcome of all of this will be that at the end of it, we will have imparted some information that will be all brand new to you and very usable. So the learning network summits that we are putting together here today are to support the very important information around how the new world looks like. We've had so many changes, and as social care providers, I think we always struggle. We always struggle with trying to get our heads around what the NHS is doing next. So this is an opportunity for you to get an idea of how it looks, and I'm delighted to be joined by my co-chair, Sir David Bean, who will be able to impart a lot of and some of the kind of more strategic information that you require. The important thing for me as a representative of social care provision, and I have been for quite some time, as some of you may or may not know, is that we have to stick to the core values of social care. When we are looking at this, we must remember what underpins social care. And that's about independence, it's about choice, and it's about control. And that's not just locally, it's not just nationally, it's actually an overall piece that is extremely important to us. That the people that we support, the people that we care for, come to us under the promise that we will be able to do some or all of that for them most of the time. And there are times where things become quite challenging. And to try and do that in partnership with colleagues and collaborate with the new world that we are now looking at in this kind of integrated approach with the NHS is really key. So I think that's part of what we want to learn, and I'm really hoping that we will get some of the experiences shared through today that will assist us in our local area, in our individual thinking, and in our collaborative thinking. What we do know is that the workforce is a critical part, and it has to be the key part that we think about. Currently, we all know that we're experiencing high levels of challenge when it comes to our workforce, both in the social care sector and in the healthcare sector. From the social care sector perspective, of course, we're carrying many more vacancies than we have done in a very, very long time. And that is creating critical capacity issues for us within the sector, especially when you think about our home care colleagues, because the time that's required to be enable people to deliver that care is much greater. So you need a greater workforce, but also in our home, in the home care sector and across the piece. And we're talking about this. I don't want us to just be thinking about older people. I want us to be remembering that we've got learning disability services and many other services that we support. And that is what social care is. So it is a really important part of what we do. We could be given all the money in the world, but if we didn't have the workforce to deliver it, we're not going to succeed. So I think that is critical. There has been long-term underfunding, and we know that we hope that it will change, but we know that the changes will be very tweaked and slight. Short-term funding doesn't help us in any way. So I think from that perspective, it is key for those of you who are listening who work with the social care sector or in the social care sector or part of that social care sector are more vocal about some of these things within your local areas as well. We have a key role to play here. We really do. And I know we sometimes don't think we do. Getting round tables which are making strategic decisions can be extremely difficult. But actually, without social care, that table will be very, very badly served. Because if the same people are sitting around the table that have always sat around the table, they may come up with the same solutions. Bring social care in around that table. Enable us to be there and talk to you in the way that's required to make the difference that it needs to make in the communities and to the individuals that we're caring for. And for our social care partners that may be listening into this, it's important that when you get round a strategic table, you think about it strategically. It's very easy to only think about it from your own perspective. But actually, when we do get round those tables, we have to think about it in a much wider, holistic way. And funding will always come up as a challenge. But let's mark that as being a challenge that we all face, and try and move this forward so that the new way of working with the integrated boards at all levels, let's try and make that difference, and let's challenge ourselves and others to ensure that social care is an integral part of everything we do. So that's my ask of today, and I hope that it's helpful. I'm absolutely delighted now to introduce my co-chair, Sir David Bean, who's a non-exec director of NHS England and the chair of Health Education England. So over to you, David, for your introduction.
Thanks, Nardra. Can you hear me? Yep. Good. Thumbs up. So it's a real pleasure to spend time with you all this afternoon and share with Nardra. Nardra and I go back a very long way to when I was Director of Social Services in Greenwich, and she helped me set up a care association in Greenwich based on her experience in Kent. So it's really nice as I get right to the end of my career to be sharing a platform with Nardra, who's been a remarkable champion for social care over that period. As Nardra said, I chair Health Education England. I also sit on the board of NHS England, but I have a long career and history in social care. So I bring that perspective to this conversation. And the challenge we've got here in England in terms of health and social care is largely driven by demography. We've got a rising number of very elderly people who have complex and comorbid conditions, which are going to require people accessing health care and support. And no one agency, no one organisation can provide all the services that people with complex comorbid conditions require. And therefore, it's essential, as Nardra has said, that we work collaboratively together. And the changes which found their shape in the bill which received royal assent in the summer and introduced integrated care boards, integrated care systems, integrated care partnerships was a significant development. The reason it was significant is that it defined collaboration, working together across organisational boundaries and between different organisations and different professionals as being the defining and organising principle of the way that health and care should be brought together. So we've got a real opportunity amidst all the challenges we face around workforce, as Nardra has said, around delayed transfers of care and all those things that you'll be familiar with, but a real opportunity with ICSs and the partnerships that support them to actually think about how we can both improve the quality of health and care and support, but how we can develop a response based on collaboration and use the expertise and the knowledge that social care providers have got to actually meet the needs of people with complex conditions. And I think this series of events is significant because colleagues in NHS England, whose job it is to support adult social care, have really taken up the initiative to develop the relationship, not with local authorities and not just with local authorities, but directly with providers. And the significance of today's event, in my mind, is the engagement of those of you that are directly providing services with colleagues who are in the new roles in the ICBs and the ICPs and the ICSs. And I think what we've got is a real opportunity, as Nordra has said, to develop a dialogue which allows ICSs to engage directly with care providers and establish the best ways of working, but also for care providers to begin to consider how local collaboration can help them develop a response to meeting the needs of the communities that they operate in and the communities that they jointly serve with local authority and ICB colleagues. And it's that collaboration which is going to be the basis for finding long-term solutions to some of the immediate pressures that we face today. So I hope, as Nordra has said, we can develop a dialogue, not just over the course of the next hour or so, but over this series of events that are being organised between the Care Providers Alliance and NHS England to find solutions to some of the challenges that we find. So, so that's what I would like to say by way of introduction, colleagues, and Nordra. And I think my job now is to invite you to use Slido, and I think you can join Slido by using your camera on your mobile device, probably your phone, maybe an iPad, to go on to the diagram on the slide that's up. Oh, it's just disappeared. On the slide that's up, I hope you got your cameras out quickly. On the slide that's up, and there'll be two questions. There it is. Brilliant. Thank you. There are two questions on there, and I wonder if you could just join Slido, and that's the code that you need to enter to get in. And there are two questions on there, and I wonder if you could answer the questions. And I am reassured by the technology gurus that in a second we'll get a live feed coming up, and we'll be able to see the answers to the two questions. What sector do you represent? That just gives us an idea of who's on the call. Secondly, what level of involvement do care providers have within your ICS at present? And that's the key question I think we're looking to get. So over to you, and you can see the live feed coming through and beginning to give you a sense of what's going on. Should be able to check how many people are on and therefore what the percentages are. No, I can't do that. Somebody should be able to tell us how many people are on the call. The last time I saw it was about 150, so 35% of 150 is broadly about 50, isn't it? So don't think those proportions are going to change overly much, are they, as they come through? So the first one was how many and what backgrounds we're from. And then this is, in many respects, the key one, which is what's the degree of involvement that care providers have within the ICS at present? There was a message there, wasn't there? Oh, Victoria's saying 100 responders, and that's 35% of the 100 from adult social care. So that's about 33, isn't it? Thanks, Victoria. So about 42% feel that they're involved. Yeah, so that's going to be about 38. What is it? 58, 60% not involved, and let's just work on the 100 or so that are coming through. So actually, Nadra, probably one of the things we want to see during the course of these sessions that we're organising over a period of time through NHS England and the Care Providers Alliance is to begin to see some of these data shifts. So we've got more people directly involved, and we'll begin to reduce these don't knows down. And I know we've got sessions from colleagues in West Yorkshire about what the partnerships are doing there and how they come through. So opportunities, I think, to learn from what's going on in some of the ICSs, ICBs across the country as we go forward. So I think we've got the general feel for that. Are we content to move on, colleagues? Thanks to those of you on Slido for just giving us that live information. And my job now is to, and I can't, yes, I can see him, is to introduce Joe Armour, who's a senior policy advisor in integration in the Department of Health and Social Care. And Joe is going to spend the next 10 minutes or so just outlining the policy background and the context and the adult social care principles for ICPs. A lot of work has been done on the policy, and this is one of the opportunities to begin to convert that policy into the lived reality. Joe, over to you. Thank you.
Thank you, Sir David. Thank you, Nadra. So I won't dwell on this too much following my introduction, but yes, I work in DHSC on integration of kind of more generally in the implementation of integrated care systems, in particular integrated care partnerships. So we'll talk mostly focus on integrated care partnerships in this for reasons which I'll explain in my slides. Can we move to the next slide, please? Thank you. So what you will see, and I think it's always helpful to spell this out only for people who have not seen this before. Integrated care systems is an umbrella term for lots of different organisations who are all working together to improve population care. There are particular statutory bodies and law that are in there. In particular, integrated care boards are the NHS commissioning body. They commission healthcare services in an integrated care system. They're a statutory body, they're an NHS body in there. And the Integrated Care Board, alongside local authorities with responsibility for commissioning social services, have a statutory duty to create a joint committee called the Integrated Care Partnership, where they can appoint wider partners and members, and that often has included district councils, health and care providers, we've seen housing, we've seen VCSE organisations involved there, and quite a vast variety, and there has been quite a wide range of variation across the country, as we have not been prescriptive about who needs to sit on there other than the Integrated Care Board and the local authorities, but whilst being very clear that you do need that wider engagement and membership to really create and deliver on integrated care as an intention on there. So as said, I will focus particularly on integrated care partnerships on the next slide. So integrated care partnerships, as I said, only have a required membership of all partner local authorities with responsibility for commissioning social services and the Integrated Care Board, and there are a range of other members to be appointed. And so over the summer we looked at a vast variety of membership lists from integrated care partnerships, and I think this is really interesting, is to kind of see the variation of where we're seeing engagement across the country. I've only given a snapshot here because there's about 30 or 40 different people and organisations who've been getting involved in integrated care partnerships, but to kind of give the most relevant ones here. So we've seen a real sort of variety of people involved. We often see directors of adult social services involved. We often see elected local authority members, typically the member for adult social care, the local elected councillor. We see lots of representation from the voluntary community and social enterprise sector, normally through sort of representation of the voluntary alliances. And I think what is really stark on this, and we are well aware of it, is that adult social care providers on the whole are not represented across the board on all integrated care partnerships. And I should say now that we've always said that membership is not the only way to involvement, but we have made it very important. We see it as very important that adult social care providers are involved in the work of their integrated care partnership, not only as a delivery partner, but as a strategic partner. And we say this because this is how you get those really relevant insights about what happens on the front line, and the needs of the people that you support and care for helps support some of that. But it's a new way of working, and there are lots of learning on there. So that is some of the basics in there. And I've seen there's a question in the chat immediately. We can send you a link of all of the integrated care partnership chairs on the NHS England website in there, so we can reply to that in a moment, I'm sure. So I'll move on to sort of some of the recent history and where we've come from and where we're coming to with some of this. So the Health and Care Act introduced statutory elements to integrated care systems. They were voluntary previously, and they are now becoming much, they became part of the Health and Care Act, made sure that there's one across in every part of the country. But we also recognise that we changed the structures of how integrated care systems work. We put things in law to make them happen, but we recognise that you can't always change. The law cannot change culture and relationships, and that is a very much a softer thing. We can bring people together. We can make it easier to work together. What we cannot do is we cannot make that happen, and lots of that requires close working, and we can help guide that, and some of this is what we're sort of setting out to do. And during the course of the passage of the bill, stakeholders and a variety of representative bodies, including the Care Providers Alliance and their members, raised concerns about the involvement of adult social care providers in integrated care systems. And it's something that we were very aware of and recognise that the sector have a particular contribution here to make on integrated care systems. So we worked very closely with the National Care Forum, NHS England, and the Local Government Association to develop principles and expected ways of working between integrated care partnerships as kind of the junction of all of the integration in a local area, and all the bodies coming together. And so we developed these and with them and published them in July 2022, and we're very proud to have those endorsed by the Care Providers Alliance, a sort of recognition of these are things that we want to be putting forward to integrated care systems. And then I can't really talk about them without talking about what we wrote in them and what the principles are. So we published this in July 2022, and it set expectations about how we expect us, DHSC, NHS England, Local Government Association, Care Providers Alliance, how we expect providers and integrated care partnerships to work together, including based on these 5 principles here, which is, I will just pull up on my screen so I get them all right. So partnership. So we see this fundamentally as adult social care providers are critical partners in the planning, delivery, and the role in improving care and outcomes. I think there has been before a conception that adult social care providers are the kind of delivery partners. They are the ones who you commission to deliver services, but you also have a massive role in understanding the needs of the people that you support and care for, and fundamentally also see where things go wrong and don't work on the front line. We always recognise that integration happens at a very local level, and when things don't go right, you are often the first ones to see it or hear about it, and therefore you have a real role in influencing how that strategy works. So we think that's really wide, and we also say this partnership is really wide as well. We talk about adult social care providers in here particularly, but we recognise it's a huge variety of organisations that make up the adult social care sector, and a huge variety of people and communities who use it and support it. So we recognise that the partnership doesn't just stop at providers. You have to be working with voluntary and community and social enterprise organisations. You need to be working with people who are unpaid carers, charities, people with lived experience of supporting care. And this isn't always about membership, because membership isn't always appropriate. Sitting in long meetings that last for hours isn't the best way to always involve people, and we haven't always said therefore you should have a seat at the table, because there might be other ways and more appropriate ways of doing it. And so we've left that at local discretion, because there is no really one-size-fits-all approach that works for everyone. We've also said that integrated care partnerships and providers should collectively support the whole of the adult social care voice to be heard. And I say this because adult social care are strategic partners, they're delivery partners, but the sector is hugely diverse, and there is such a range of different provision that exists in any area of the country, and it will look quite different. And some people will have more capacity to be involved in strategic direction setting and planning than others. So we've always said that there should be thought and given to how you can involve people and support their involvement as well, and make sure that that breadth of the adult social care sector is really represented within that. And in particular, we've said in there that it can help for the integrated care system to have networks such as care associations to help advocate for a range of providers. So I'm really pleased to be here and be working alongside National Care Association colleagues on this. Thirdly, we use the principle of subsidiarity, and that is a fancy word to say decisions should be made as close to the people they affect as possible, which means that whilst we have these system approaches which sit across multiple local authority areas, sometimes those decisions are best made even more locally if possible. And so really that is what that is about, and making sure that partnership arrangements work both at kind of your city level, your borough level, in your neighbourhood, in those communities that you work in, because actually fundamentally that is where integration happens. It is when different organisations work closely together on the ground to improve and meet the needs of their patients. And then finally, knowledge sharing. So ICPs should also facilitate sharing of knowledge across places and systems to improve health and care services. And this is, if there's something that is going well or not going well, it should be that those being shared and cascaded across the integrated care partnership, because different areas will have different experiences and you can all learn from each other. So it's brilliant to have a learning summit here to do that so nationally as well. So I will stop there. I've talked for too long, but there are questions I've seen that come in the chat, and I will try and either answer some of those as we go, but I'll pass on to Simon.
Okay, thank you very much. I don't have any slides, and I'll try and be brief to make up some time. Thank you very much for the opportunity to comment from the viewpoint of local government. And the first thing to say is we warmly welcome everything that's been said this morning and this initiative to really involve social care providers in integrated care partnerships. We took a proposal to the local government sounding board about a month ago, which is made up of kind of councillors, chief executives, directors of adult social services, and it received a warm welcome there. At a personal level, I would say the last 3 years has been incredibly tough for the sector, as we know. But if there's been anything positive that's come out of it, one of them has been, I think we've discovered at a national level how much better we are together, local government and providers working together. I think it's had two major benefits. One is that by having a unified voice, we are just so much stronger together in how we advocate for social care and people who draw on social care. And secondly, we've found much better solutions in many cases to some of the things that have been, that needed solutions, if we've been prepared to kind of listen openly to each other, not come in with preformed ideas that we won't move off from, and actually really trying to find the best possible solution. So that's why I'm personally really pleased to be part of this. And I think we know that a lot of that also happens at a local level already, that kind of level of mutual respect between providers and statutory organisations, but probably in some places there's further to go. So we very much want to be part of this process of helping all ICPs kind of, do all the things that Joe's just explained really fully and really helpfully. I'm just going to make 4 just kind of suggestions basically, and then I'll kind of finish, or things to think about. I think the first thing is that we in local government have to be clear we don't speak for the whole sector. We're the commissioners, so we have a kind of responsibility, but that doesn't mean we can claim to speak either for providers or indeed for people who draw on social care, and we need to kind of take that on board. But secondly, on the other hand, we need to also remember local government has a duty of market oversight. So we have a statutory duty to do that, and we very much hope that we can make this work with our partners, respecting that that's a responsibility we do have. Thirdly, we know that these things won't happen sort of true getting providers truly kind of to be part of strategic decision making won't just happen by accident, probably won't happen with some level of resource and organisation being found, especially if we want to involve SME providers. We need to find practical solutions to that. And the great thing is, up and down the country, we know there's been some really good experience of how people have done that. And then probably the last point, and I think it's part of my personal journey in the last 3 years, is sometimes you just have to be brave as partners and accept if we differ, and accept if we've kind of got it wrong, and be prepared to actively kind of explore that with partners, and be prepared to kind of open things up in a transparent way. And my experience throughout that is that I've always found providers incredibly gracious when and sort of positive when we've said, well, can we find a better way of doing that? So it's very much an encouragement to kind of let's try and not be defensive as we kind of go into this. Thank you very much for the opportunity to comment. I'm afraid I can't stay longer in this session this morning, but as Cecily and others know, I've been kind of part of this conversation for a while now, and I'd be really happy to give any further support to this as we go along. Thank you very much.
Okay, I think I'm being guided to a couple of questions to come to Joe and Simon, please. And you both acknowledged just we're up against it in terms of the timetable. So if you could be crisp. Questions, I've got two. How can we ensure that people who draw on social care are at the table as part of the provider role? So that's question one. So it's about the engagement of people using services, basically. And then secondly, how can care providers directly interact at ICB level so that a medical model does not dominate? There are other questions in the comments, and I think from the organisers' perspective, we'll work out how to get answers to you in some of those. There's a couple that are challenges to me, and I'm quite happy to come back with some narrative that you can put out through the system. So, but Joe, do you want to have a go at those two questions, please? And then Simon, I'll link to you, and then I'll hand over to you, Nordra. Joe, please.
Thanks very much. Every integrated care board and every integrated care partnership should have an engagement strategy, and they're required to have one by NHS England in this, and so they should be available on the integrated care system on the integrated care board website. So I first of all go look at that. They will each set out how they plan to engage, and everywhere will do it slightly differently. It is really important that we get these voices in there, and that is why we have seen in almost all integrated care partnerships that Health Watch is the advocates for. People who draw on care and patients are have a seat at a table and use that representation, but we recognise that's only one avenue to do it, and there's lots more engagement in developing the strategies. Secondly, why do I think, how do care providers interact at ICB level? I think this is the integrated care partnership who have so much of this. The integrated care board is an important thing in there, and this is how you develop those integrated care strategies, the strategies that set up for the integrated care system about how you develop a model of care which fundamentally works and isn't just about medicalising care or anything, but actually about meeting the needs of the people who need those services in a kind of holistic and joined up way in there. I'll stop there. I hope that was crisp enough.
Simon?
Yeah, so on the first question, essential that we make a distinction between people who actually draw on social care and providers, although often, and that'll vary according to kind of local places. Health Watch is an obvious starting place. Some places may have something like a Centre for Independent Living, and other places might be using the local VSCE to kind of draw a composite view from kind of local voluntary organisations who speak for those who draw on social care. So it's not one size fits all. It's just working it through locally, how best to make that work. And on the second point, I think this is my point about being stronger when we speak together. I just think the essential thing is that ICBs get a social care perspective along with a social model of disability and those things that we kind of hold dear to our heart, and personalisation and the like. And I think by working together doesn't mean that every single organisation's got to have a full place on the ICB board, because that might or might not happen. What it does mean is that we can find ways of kind of getting that, ensuring that that perspective comes across to ICB board members. That would be my kind of, that's what I would encourage. It's kind of, yes, by all means strike to get the formal positions on these boards, but there's still plenty that we can do as a sector working together to kind of influence that culture and decision making.
Yeah, there's an important distinction between involvement and participation. In one, you're there all the time, and in the other, you come in and out at different times. But Nordra, can I hand over to you to take us on to the next stage, please? Thanks.
Yes, thank you. Thank you very much, David. And I think like really interesting kind of perspectives, and the importance of the sector being underlined consistently, which is great to hear. So we've got a session now with three different elements to it, and everyone's got 10 minutes. I'm going to try really hard, and I hope you will as well, to keep to that 10 minutes just to keep us on track. We're going to start with Les Jeffs, who's the CEO of Avondale Care and board member of Kent Integrated Care Alliance. Then Michelle Atkinson and Kate Sims, who's Chief Officer, Leeds Care Association, and Director of People of West Yorkshire, respectively. And then Rosa, I knew I was going to get this one wrong. I knew it. And Napolitano. Have I got it right? My apologies if I haven't. Executive Director of Business Development and Innovation of Look Ahead. So if you will all just take the 10 minutes, that I'll be extremely grateful.
Hello, everybody. My name's Les Jeffs, and I've been a KICA board member since 2015 and heading up the Kent Social Care Organisation. So I'd like to address this issue by asking a number of questions, and one of them is contained on the PowerPoint slide there, by asking a number of questions and hopefully giving some insight concerning how things are in Kent. KICA has worked hard to facilitate links between the provider sector and the commissioning local authorities since KICA was established in 2014. And since then, efforts have been made on a regular basis through training and educational opportunities to help the sector develop insights into effective practice and to bring together relevant stakeholders. Notably, KICA has arranged a provider forum to take place at the end of January in order to inject some energy and insight into the new arrangements by bringing together the chair and the CEO of the Integrated Care Board, as well as the Director of Kent Adult Social Care. And I think seeing those persons sharing a platform will give providers a sense that genuine collaboration may be in the offing. And it's worth noting that social care providers are represented on the Integrated Partnership Board, that the chair of KICA also sits as chairman of the Care Sector Workforce Steering Group, which feeds directly into the ICB. Additionally, KICA was party to the Together We Can symposium organised by the integrated care system, which was held in the autumn of 2022 as part of engagement with all stakeholders. The position in Kent and Medway is one characterised by the increasingly restricted financial resources of the local authority. People have referenced this already. Local authority funding reduced year on year over the past decade by central government has over time resulted in commissioning practices which reflect the local authority's need to harbour its resources in the very best possible way. And this means that providers of social care in Kent and Medway have consistently experienced a contracting relationship which is about producing a service largely utilitarian in nature, a relationship designed to spread the resources widely and as a result often quite thinly, as providers report. Next slide, please. The question on the next slide, how do these contracting principles translate into social care activity? Brings this response. Well, notably in domiciliary care, but also in other domains of activity, and we all know this story, principles of time and task have largely applied for contracted providers, eking out the contents of the public purse to satisfy perhaps as many people as possible for the sums available. Next slide, please. What social care providers say is that there is an emphasis on tasks largely defined by their practical functionality rather than by any concept relating to human flourishing and a robust, sustainable recovery. There is not a lot of time for relationship, for responding to the person's wider societal needs or communicating those needs in the right quarter. Robust preventative recovery is harder to achieve. Similarly, the limited adoption of joint commissioning protocols means that providers still witness, too often I'm afraid, the loss or the abandonment of individual social care referrals. And when the local authority funds a social care placement, the protocols around what proportion is health and what is social care remain challenging. And next slide, please. Social care workers in Kent and Medway report that they feel sometimes discouragingly restricted in the scope of their activity. Their natural instinct is to be practically and widely effective, but save for exceptional circumstances, they are not consistently able to do so. It can be discouraging. So how can social care providers move from this rather discouraging position to something which amounts to an energetic and enthusiastic support for the new partnership? Well, commentators such as Martin Green and Camilla Cavendish and others have all represented very sensible views about the difficulties that social care providers face and what might need to be done on a practical, financial and educational basis. And I don't propose to rehearse those views, but some observe it would be useful to have parity with equivalent disciplines within the NHS, recognised training and a career path, as well as a consequent raising of esteem. In the main, providers report a compromised sense of self-worth, mirroring only very modest enthusiasm about the propriety of their social care interventions from local authority operational teams, especially if they stray beyond the restrictive contractual expectations. And providers hope that the ICS structure can drive improvements. Next slide, please. Well, to sign up to a cause, first you need to believe that the leaders have a realisable vision. Following on from the Together We Can symposium, in which the ICB set out its vision, the upcoming KICA forum should give leaders of all member organisations the opportunity to hear from the persons who are going to be shaping the environment in which social care is to operate over the next few years. those providers need to be persuaded that they are genuinely to be regarded as partners in a new era of shared enterprise. Handsome is as handsome does. Well, this aphorism may seem trite, but it is perhaps relevant. Social care providers need to see the development of overarching cost-sharing protocols in order to develop a system that they feel as though they can rely upon. By way of example, perhaps I can cite provision of community mental health services using social care providers. For some time, providers in this domain have found themselves responding to the urgent needs of mental health professionals for a particular client, sourcing effective community support in order to diminish the possibility of future relapse, only to find that the local authority resource for such activity is insufficient to achieve that type of outcome. One partner has not consistently been able to support the other, and social care providers proposing responsive interventions have found themselves in the midst of this standoff. Providers do remember that the local authority has always adopted, because they have to run a balanced budget, a cautious attitude to supporting the wider health and care system, with all of the consequent costs that would come with enthusiastically doing so. So providers see a relationship which is largely transactional. Wider outcomes for people can become incidental. The effectiveness of the relationship between the County Council and the health service in Kent is fundamental to provider confidence, knowing that the wider system in Kent is not dependent almost exclusively on very hard-pressed local authority budgets. So clarity and reassurance on this point would be very helpful to providers considering the further expenditure of time and financial resources in support of the new system. Providers have noted the usefulness of collaborative discharge to assess commissioning, and more recently the programme to facilitate the discharge of persons with learning disability and other problems from long-stay hospital using trained social care staff, and that's seen as a successful model. And KICA is further encouraged by work with our elderly population, which care staff see on a regular basis through enhanced health in care homes, the Restore 2 programme helping care home staff manage the health of residents proactively, and an admirable end-of-life protocol. And this is very much to the credit of the new ICS-ICB arrangement. We know that such examples of health and social care commissioning as a shared enterprise between the provider, the local authority and the health service can work. So this is encouraging. It would be helpful if providers were aware of the nature of negotiation going on, or a plan being formulated which reflects this type of commissioning. So providers are likely to respond to commissioning initiatives with eagerness and alacrity when they understand that the two major commissioning bodies, along with everybody else in Kent, are working solidly in concert within the ICB, and KICA seeks to enhance this process in whichever way it can. Thank you very much, everybody.
Thank you. Thanks very much. And you kept pretty much to time, so great. So now, Michelle and Kate, over to you.
Thank you, Nadra. Hi, everyone. So I'm Michelle, today representing the Care Association Alliance for Yorkshire and the Humber. If we could just skip straight to slide 4, please. I'll just talk through the background. So if we could go to slide 4, please, the benefits. And the next one. Thank you. So just a little bit of background then. We'd had various discussions at the Care Association Alliance meetings about the introduction of the ICBs. And one of the things that we decided to do sort of outside of those meetings is sort of get together as a little group to look at what we could do to ensure really that we had a seat at the table. And one of the things that we thought was, well, actually it'd be a really good idea to sort of form a regional Care Association Alliance so that we could represent the sector at some of these strategic meetings that were taking place. And it's always been about partnership working. And I think that we were really lucky initially because sort of West Yorkshire had care associations already in place. We started developing a proposal and then realised actually we've got 3 ICPs and ICBs operating sort of across Yorkshire and the Humber. So we extended the work that we were doing and invited other care associations to come and join our little group in really. And we're now in the process of developing sort of a memorandum of understanding so that we're all working to the same core principles, we're all operating to the same values. And I think one of the things that's important to note as well here is that actually we've all the way through this while we've been doing this work and sort of having conversations, we've been working with regional Yorkshire and Humber ADAS and LGA colleagues as well. So that's been really, really beneficial to us as a group. And I think they've found some benefits as well. So we've just got up here aside about why we came together and the benefits of Regional Alliance. I suppose the one thing I would say is that it allows us to bring that expertise, that knowledge and those skills from a care provider view to the table going forward. So, and we wanted a consistent approach. And also, obviously, if you're working in a small organisation, really difficult to attend all the meetings where you need representation. So we are looking at sort of sharing resources so we can share that attendance at those meetings. So it helps everybody then. So next slide, please. Thank you. I put on this slide some examples of best practice, and I'm not going to go through them all just because of the time limits. But I think if I pull out a couple of examples, I think it's fair to say that when the fair cost of care was underway, the care associations supported and engaged with providers all the way through that exercise, and each local authority area was doing something different, but we still all supported our colleagues and encouraged them to take part, just to ensure we've got as many voices represented in those submissions that were made. We've also recently been talking about hospital discharges, as everyone else has, but more so about the Care Home Trusted Assessor programme that's been in operation in Leeds. And I'll come and talk about that in a little bit more detail a little bit further on. Next slide, please. We think that there are opportunities to explore and develop further, so the fair cost of care and its outcomes. We don't know what the outcomes are yet. We're all waiting with bated breath for the 1st of February so we can have a look at what's been submitted and look at how we can work together and see where the commonalities are. In terms of the ICS, we want a stronger voice. We want to represent the sector at those very important strategic meetings that take place. So if we're all working together, it does give us a stronger voice. We actually think that by working together as a Yorkshire and Humber Care Association, that gives us opportunities as well to look at training initiatives and quality improvements that can be rolled out across all providers working across Yorkshire and Humber. Really important piece of work around workforce strategy, and I will mention that a little bit further on in our 10-point plan. But also we want to look at how we can implement new legislation and practice together across Yorkshire and Humber, but trying to utilise the same implementation plans. And I think that's really key, because what we find is that what happens in one local authority area is not necessarily happening in another authority area. So you get some pieces of work being implemented, but implemented differently. And if you're a provider operating across several of those authority areas, it can be problematic and time consuming. So we want to look at how we can work together more closely. Next slide, please. So where are we now? We held a crisis in care summit with partners from the local authority and NHS back in October, and as a result of that summit, we've actually now developed and agreed an action plan with our partners. We are developing links slowly with ICB and ICB partners, but you know, it's been difficult, not quite sure who to go and talk to and when, but we are getting there. It's been really good working with ADAS because it's given us the opportunity to collaborate and co-produce things, and we are actively engaged and supported to look at developing regional initiatives, and I am going to talk about a couple of those regional initiatives in a moment. Next slide, please. There are areas for improvement. I think having the right people involved at the right time is crucial, but it's not always easy to identify who those right people are, and people do change job roles, so you're then starting again in terms of developing those relationships. It does sometimes feel like one step forward and two steps back, so take the small steps, take any opportunities that you're offered. And I think it's important to note that different places are at different stages of development as well, and that can sometimes be a hindrance to where you think you need to be. So, but just bear that in mind. And I think a big one really is about making sure that there are adequate resources to enable meaningful contributions. It's really difficult when you work in a small organisation to ensure that those resources are available to sit down and have the conversations and participate in meetings. Next slide, please. So there are opportunities. Small steps lead to bigger things. I've mentioned relationships do take time to develop, but they are developing slowly, and that's really, really important. We are establishing good links now. I think it's fair to say that there are still more links to be made, especially if we do want to be represented at that ICP, ICS level. And it's really helpful where we've got local authorities that do go to meetings and say, have you thought about inviting the local care association? Have you spoken to Louise? Have you spoken to Michelle or James or whoever? One of the things that we've been able to do by coming together is share good practice, and that's been really, really helpful, especially for those organisations, the care associations that sort of just forming or have only newly been developed. And then in terms of joint initiatives, I just want to spend a couple of minutes talking about our 10-point action plan that we've developed.
We're quite tight. Sorry, we're quite tight on time.
Okay,
so.
I'll send some further information around about that then, and the role of the Care Home Trust Assessors, because I'd really like for Kate Sims, People Director at West Yorkshire Integrated Care Board, to be able to join the conversation and give us their perspective on how it is to work with us, if that's okay. Thank you.
Thank you very much. I can feel that there's so much more you want to say. It's just the time, so my apologies for that. But there'll be questions that might tease out some of the things that you've said. So I'm going to hand over to Rosa now for your 10 minutes.
Okay. So
thank you.
Thanks. Hi everybody. I'll try and keep this brief as I know we're running slightly over. So I've been asked to give a provider overview of how to engage with an ICS and how to co-design different models. So I think the poll that happened earlier on this webinar with Sir David, which had a suggestion that only 5% were very involved, might be quite helpful. Next slide, please. So just to give you a brief overview, so I could work for a provider that operates in London and the South East, so we're not national, but because we're across London and the South East, we cover multiple ICSs, so we don't fit neatly into the geography, and we have about 140 services. So when we try to have conversations, they happen with varying elements of success, and I think my advice to the providers that are on the call would be that you have to kind of push where there are open doors if you work across multiple geographies, develop those relationships, and then pick up with the other ICSs and ICBs as they develop, because everybody's operating at different levels at the moment. So next slide, please. So for those of you, so apologies to the 20% of ICBs and ICSs that are on this call, but this is just a very quick slide to help those that aren't understand how this works. So typically now, under the new system, commissioning will happen on a geography basis. So it's system, place and neighbourhood. So the good news is that this is now, there's a shift away from what has been siloed working in the past to everybody getting their heads together and really thinking about how they can improve the health and the well-being of the locality. So the push from government is now basically saying that you need to analyse who needs the support, where the support needs to happen and who needs the support. The bad news is on the next slide. So for those of you who live in Ealing, apologies, this is an old slide, it might be slightly out of date, but basically it's a complicated picture. And this just shows you the multitude of people that are sat across an ICS geography and how they need and how it needs to integrate. It's a bit like a spaghetti junction, and we've got kind of the VSE sector in the top left of the slide, out of hospital in the bottom left, and mental health. And it's quite difficult, as some of the providers on the call have said, to navigate who to talk to and where. And I think what you need to think about is, although these are all the providers in the area, we need to really focus on the patient and the service user endpoint, because it's not just about systems, it's not just about organisations. The whole point of this new way of working with ICSs is actually to deliver a better service to the end user. So I think this system mapping can make it difficult for you to get your offer across and to work out where you fit in. And obviously there's been links sent around as to where that starting point might help. The positives are, I think, if the new if there's a new government at the next general election, I think the positives of this new system is that it will avoid duplication. If this continues to bed in and people continue to talk to each other across providers, across health, across housing, it will shift and change, and it will provide better pathways for people, and it will enable geographies to really use the data that they have and focus on prevention and early intervention, which should lead to better outcomes, because obviously over time the UK is starting to lag behind on quite a lot of its outcomes compared to the rest of Europe. And so I think by taking this geography based approach, and for providers to actively help and support this with NHS colleagues, it will lead to a much better system going forward. So next slide, please. So I've been asked to talk to you about a couple of things that we've been working on. And so we've had two different experiences in two different ICSs. So the first one is with the North Central London ICS. And so we've been working with Camden and Islington now since COVID monies were available in 2020. And we put together a hospital discharge service to help with bed capacity. And so that service included in-reach into the ward. It's given them significant financial savings, which meant even after COVID monies ended, they used winter pressures monies, and now they're finding other pots of money to continue the funding. It's reduced their readmission rates from 10% down to 3%, and they're kind of steady now at a 5% level across the work. And it's reduced the number of bed days that they've had as well. And then I think for them, the biggest issue is that it means that now their bed capacity is improved to the point that they can offer their beds, their inpatient beds, to their neighbours. And it means that they have then not had to pay for expensive out of area placements. And so because obviously everyone's now in an ICS position, it helps the bottom line for everybody. And so that's one example where it was started out as a really small pilot. We used an iterative process throughout that, listening to what they needed. We adjusted things within the pilot that we're working on, to the point that it's gone through various different iterations. We've added in medication management, we've now expanded the number of workers, we put in honorary contracts, they go to bed meetings. We sort of did our learning throughout the project, which has really helped for us being flexible and to give the commissioners what they wanted. And then the other one is in Newham, and so apologies. And so that started out as us taking on a very low level mental health service across 4 buildings. And this has been a transformation piece of work. And so we've worked with colleagues in the Mental Health Trust and the local authority. We've now remodelled the service to take much higher people. We've remodelled the buildings to allow them to take DOLS patients. We've added in floating support so that we can move people that are stuck in those services out, so that they can use that pathway now as a step down from hospital. So obviously everyone's in the midst of a winter pressures funding conundrum and trying to get people out of hospital. We've now used that service to move people out of hospital with being bed blocked into one of our services, which has also helped them. And so from that piece of work, we've now expanded our conversation with them, and we're having strategic mapping meetings looking at the rest of our buildings and our pathways. And so I think that's kind of that's where providers need to take something away from this. You may be doing this already, but I think you need to not have fixed models about what you're offering. You need to think about how can you be flexible and how can you do things that will support the needs of the healthcare system and the ICS mapping, and think about things in a longer term way. So my last slide is the next slide. So this is just kind of a very quick do's and don'ts of how I think providers and how we've approached our relationships with ICSs. So we've looked at this as an equal partner. We've brought maturity to the relationship. We know that having conversations now with ICS partners, it's more of a collaborative conversation. It's not a strict commissioner provider relationship anymore. The new ICSs have given opportunities for us to have mapping meetings and conversations before services are commissioned, and because there's pots of money around from NHS funds, you can go in and start doing pilots and test what works and do evaluations. So my kind of do's to people on the call that are from ICS is basically to try and understand your ICS geography. If you work within one area, you're obviously more limited if the ICSs are not really talking to you. My suggestion would be to read their priorities and plans. Everyone's publishing everything on their websites, so trawl through that, read documents, understand what their thinking's at and where they're at and what they're looking to do. And then I think when you get those face-to-face meetings or you meet people at events, it's to listen to what they need. And when you have subsequent meetings, it's to listen to what they need. This won't work if we all come with fixed ideas of what needs to happen. It has to be a process of learning. And then I think when service models are being thought about and tested, it's about making sure that service users and patients have their feedback within that. So that's already been mentioned on here, but I think it's really important. So some of the iterations we did in our Camden and Islington hospital discharge was a result of what patients were telling us would be helpful for them. So we put in a welfare fund to pay for various things that people needed, and kind of expanded the amount that we'd allocated, because that did help to discharge people quickly. So I think that the patient service feedback is really key. And then I think it's about building in time just to think about what's needed. You don't have to have meetings that have an agenda about what service are we going to buy from you, or what can we offer you. It is about what are the issues that you're dealing with? How can we help? How can we think about this in the longer term? You know, there's a lot of short-termism in funding pots, and I think it's good to really think about, well, we can do this now in the next 6 months, but what do you need in the next 5 years? And I think for us, that's where we've taken some of our strategic thinking about. We have a lot of buildings in one of our areas, our ICS areas, and it's about how can we use those buildings to provide services for the ICS that will really give them the maximum benefit.
Thank you, Rosa. Have you got a lot more? It's just
no. So my last don't is basically just don't be short term. Relationships take time, and I think you just need to invest in that. And that's it from me. Thanks.
Thank you so much. And I feel terrible because I'm rushing people, but I feel even worse because I didn't bring Kate in. So what I am going to do is, I mean, I think there's so much information. It's one of those challenges, isn't it, when you've got so much packed in and all of it is so important. But Kate, can I give you a few moments to just come in and raise, because there's been a lot of questions around and people are desperate to hear from you. So would you mind just doing a few moments for us?
Thank you very much. Can you hear me? I think you can hear me. Yeah. Hello, everyone. I'm Kate Sims. I am the Director of People at the West Yorkshire Integrated Care Board. I won't take up too much time, but what I would say is this is an evolving and absolutely developing picture. So I'm sure there'll be some questions that we'd be happy to come back and talk to people as our own work develops. It's fair to say when I arrived at the ICB last summer, the people agenda across our ICB, our system, our West Yorkshire system, is significant, as it will be across the country. But what became really apparent to me very, very quickly is particularly around the area of social care and all of our care organisations. I have been absolutely delighted to work directly and closely with all of our directors of adult social services, but also our chief execs and their colleagues in the care associations, because how do I otherwise get that reach right across West Yorkshire would have been a real challenge. I think very briefly, I think many of the workforce challenges will be very similar across the country. The sorts of themes that we'd get into is about how do we attract people, particularly in the current with the current labour market challenges, but more importantly, how do we develop people, retain them and look after them within their roles. So I think it'd be no surprise that some of the work that we're doing, which has been touched on by Michelle, is very much looking at those actions. And I agree with what Rose has just said. This is a long-term relationship as far as I'm concerned. So we are working, as Michelle said, I'm working directly with the Yorkshire and Humber DASs, but also with the care associations. So I'm regarded as one of the workforce leads to work directly with one of the care associations to look at some of those practical aspects around things like one workforce recruitment campaigns. Across the system, we also think, well, what's the scope of the system to support our colleagues within all of our care sectors? And a really practical example for us is the wellbeing journey. So like most sort of areas of the country, we have got and we've now secured it for the permanency, a long-term health and wellbeing hub, which is accessible to all of our staff. So that's an example of something where we would say it needs to be available to all. We had our ICB public board last week, and it's first time that its full focus was on workforce. So it's really important to me that social care and the care sector became one of the key presenters. So a colleague who's on the call here today, Louise Beswick from the Bradford Care Association, and one of our DASs was one of our main presenters, because for me it was really important that our board and all of the people who were watching, because it was live streamed, actually heard that this is a key area of the workforce strategy going forward. Very, very briefly, I know I've been asked to talk specifically questions that have come in around integrated workforce planning. We're probably, at an early stage, as many people are across the country, but we are now very much, we have 5 places within West Yorkshire, and we are doing very much integrated longer term workforce planning. So that means in those places, whether it's Bradford or Leeds or Calderdale, Wakefield or Kirklees, the people sitting around the table, including colleagues from Skills for Care, are all there to talk about, OK, 1 is numbers, but 2, it's absolutely about roles going forward. It's about development of new roles, all sorts of pieces around, do we start to really push more and more of our training placements out of the perhaps where they normally are in secondary care and out into the rest of our system. So there's an awful lot of work that some of it very much in its infancy, but I'm happy to talk to people in the longer term. I'll stop there, Nadra, but I could talk for quite a lot, about the work that's currently happening, very much developing lots of active action plans across both West Yorkshire and Yorkshire and Humber.
Bless you. Thank you so much. I know there's bringing it all together. There were a lot of questions and a lot. I mean, hopefully some of the questions that were raised you've already answered. And I'm conscious of time, so I'm looking at any whether we kind of just move on with just a couple of the questions, and then David and I.
A couple of the themed areas of the questions. Yeah, Nadra, the first one about who holds the power within the system, and
Yeah,
the adult social care provider land.
Go on. You've started it, so finish, Victoria.
I think we've heard really well from actually all of these speakers about sort of reaching out and establishing different partnerships and ways of working. We would always compel people to try and be part of their local care provider organisations, or try and link up with some of the national care associations. I did see some really interesting chat from colleagues talking about 35% or sort of smaller proportions of the social care provider actually being part of that. And then some bigger questions about accountability. So how does providers and actually local authorities have accountability within the ICS and ICBs, and who can providers go to regarding engagement, and one about the role of Health Watch as well within there. So maybe some different questions for Jo and for David.
I just wonder about if we pick up the Health Watch one first, if someone's able to pick that one up. Can I, David, you seem to be, no, not David, not nominated.
I can do it, Nadra.
Okay, great, okay.
So Health Watch are involved, certainly, and it depends on local circumstances, but we've definitely seen Health Watch sit as either an observer to integrated care boards, or occasionally as a member, and that's to do often locally with whether it's appropriate for that to them to be a full member of a decision-making body, where they're also scrutinising and advocating for patients and people who draw on care and support. In terms of the role of Health Watch England as the national organisation, but also Health Watch organisations locally at every local authority, they do have a legal remit to look at both health and healthcare and the role of commissioning that in the NHS, but also the commissioning of care services commissioned by local authorities as well. So they do have that kind of wider remit. I think there was some concerns that it was health only, which the name on the tin doesn't help, but it does in fact have the two parts to that remit.
Thank you for that. I went on mute there suddenly. I just wonder about that accountability question. I wonder whether we can sort of tackle that, because there's been a huge amount of conversation around, you know, the benefits of all of this. But who does hold the power? Do we need to have this conversation about the accountability of the ICSs? Where does that really rest, and how do we have a national conversation about it? Any thoughts from anyone on that?
I'll talk about the accountability in terms of legal accountability, because I'm familiar with the legislation, but the Health Service remains accountable to ultimately Parliament through the Department for Health and Social Care and NHS England. So NHS England has the oversight of integrated care boards in particular, and they have that particular oversight role. And local authorities are accountable to the people who elect them and vote for them. There is local accountability mechanisms via the local authority in the NHS for a thing called health overview and scrutiny committees, which have the right to scrutinise the provision of work of health services, and often as an equivalent for social care services in local authorities too. So there is kind of this kind of separate accountability, and it's actually, this is why partnership working is really important. We haven't kind of just merged everyone into one, because there is different accountabilities, and that's the right thing to do in the view. But the other part of this is that the CQC is taking on it will take on new responsibilities to review integrated care systems as a whole, and this will involve not just talking to integrated care boards and integrated care partnerships, but talking to providers in the area too, which are regulated by the CQC. And this is something that they're really, you know, they're keen to do, and they are developing their plans on how to do it at the moment. And as an independent inspectorate, they have their own way of doing that. But that is something that they certainly have intended to do, and look at how they are engaging the full breadth of organisations in the integrated care system, including adult social care providers. So yeah, there's a lot of ways. It's a bit complicated, but there are certainly different things of accountability.
Thank you. I'm going to, yeah, I can see that Kate's desperate to get in, so I'm going to go to Kate first, and then I'll bring David in as well.
Apologies, I wasn't sure if there was a facility for a hand, but
I could just see you. I could just see you doing that.
Just very briefly to go back to the question around Healthwatch, a practical example. Certainly in West Yorkshire, we do have membership on our IT board, a member of our Healthwatch team, and where that's really excellent is obviously in terms of the different debates and conversations and discussions we're having. When it comes to our public board, we actually have in the morning a very big engagement session on a theme. So we've done workforce, we've looked at primary care, and we've also looked at children and young people. And where Healthwatch are really able to bring in is that engagement session of so we literally hear the voices and the lived experience, excuse me, of our patients and residents. So that's a real benefit. Absolutely, it's not the only one, but of them being on that board with us. So I just thought that would be a practical example from West Yorkshire. Thank you.
That's really helpful because it kind of brings the whole thing together, doesn't it, about how it works. So, David, your thoughts?
So I think Joe's given the legal answer of what the legislation says and set that out, and that's right. But you know, over the various roles I've had throughout my career, I think we have multiple accountabilities, and I wouldn't mind reframing the question from where does the power sit to, in this conversation, how can we have influence over what happens? And I talked earlier about complexity, particularly of some of the cases that are being presented. There's no one organisation, no one agency, and no one professional group that can actually respond to all the challenges faced by the demand that we've got. And the answer is that we need to work collaboratively and work across those organisational boundaries, barriers and professional groups. And therefore, I wonder whether it's helpful to think about a shared accountability. And I don't know what CQC are doing now, but as Joe said, they've got a responsibility for assuring the quality of the system that is delivering services to people. And I would expect CQC to take a perspective on are the partnerships working? Are they working effectively? Is the voice of people using services and the lived experience of those people being factored into the way that those partnerships are working in much the way that I think has been set out by Kate in terms of the work that they're doing at a local level in West Yorkshire, and I think Michelle was making this point as well. So I understand where the question comes from, but I wonder whether we should be thinking about how do we engage all the constituencies we need, and how do we influence the agenda which is in front of us about how we improve the quality of services and the offer, actually, the access to services, because there's an awful lot of people that need services not getting access to those services at the minute. Thanks.
Thank you, David. Thank you, everyone. I think we'll kind of move to reflections now. I think we're going to leave the poll in the interest of time, so that we can get you all away as quickly as possible. And I'll keep my thoughts very much limited, because I think what David's just said about power versus influence is enormously helpful in many ways, because we can all be exercised about the power bit, but it's actually the influencing that makes the difference. And I think that's really important. I think learned a huge amount through the day, but one of the main messages that I will take away from this is that there is so much going on that is collaborative at that local level. And some great examples have been shared. This is a new beginning, and actually there is a recognition from all the speakers who talked about social care being around the table. Simon was talking about stronger together, and I know that happened through COVID and the CPA work that we did around that. I think that benefit around the local, the regional bits are key, and we need to get providers out there engaging in that much more and making sure that they can influence where they're able to. And this, the importance in all of what I've heard today is about that collaborative approach, about that work that means that we're all going towards the same outcomes, and it's the outcomes that matter. And all the time we hold that in our heads. You know, we are all exercised about who sits on what boards, but actually I'm sure all of us will say we go to meetings and you know, you kind of come away and you think, I could have done something differently at that moment, but I didn't. We have to make that difference, and we need to be together. So all that leaves for me to say is thank you to all the speakers on my behalf. The slides, I understand, will be shared, but I'm now going to hand over to David to do the final reflections. Thank you, David.
Nodra, thanks. First, thanks to NHS England team and the Care Providers Alliance, Nodra, you and your teams that have actually organised today. I think it's been hugely constructive, so thank you. Thanks for the presenters as well. I'm struck by a number of different things. Firstly, if this was easy, we would have sorted it out years ago, and it's not easy, it's really tough. And I think what we've had during the course of today is some really good examples of what a number of you doing at a local level to make this better than it has been historically and traditionally. And Les, your comments, Michelle, yours, some really practical examples. Rosa, you talked eloquently about the difference that you have been able to make in some of your sources, places in London. So what I'd encourage others on the call to do is take great heart and some confidence from what is possible, and a real encouragement to take the opportunity that ICBs, ICSs, ICPs present to engage with this agenda. You can only do that at a local and a system level, it strikes me. You can't do that sat as I am in offices in London. It's got to be done at a local level. So a lot of the examples you've heard, I think, are really important. I think what we need to do, those of us that operate at a national level, Nodra, Cicely and the team in NHS England, is I think some of the barriers that have been flagged today to what's getting in the way of you being the best you can be at a local level. I think we need to think about those and take them away. Some of them we've got influence over, and some of them, like how 500 million gets allocated, which was one of the questions. Look, people see me as having a lot of power. I have no power or influence over either the amount that is given or how it's distributed. But we do have voice and we do have agency, and we can use that voice and agency, I think, to contribute to those conversations. I want to end on two things, though. Firstly, a number of colleagues have said just the importance of relationships. What I learned during my time, particularly working at a local level, Nodra, you helped me with this as well in the early days, is if you start with a governance, you're starting in the wrong place. Start with what it is you want to do together, work out how you're going to do that, and then put the governance in place. If I can just claim a Clinton phrase, it's all about relationships. All about relationships. So I would really encourage you to invest in developing those relationships. Now, a number of you have said it's not possible to do that because we're a small provider, we don't have the capacity. And I think this is where the narrative about the care associations is really, really important, because that is where some of the capacity sits. And I just think we need to have some further reflection on how the care associations can speak for the sector, not just their members, and actually try and articulate that in a way. And also just encourage one or two people to think about investing in the care associations as a way of articulating it. If I was sat where a number of you sat on the ICBs, I don't know how you involve numerous providers from the very large to the very small in a conversation about strategic planning, let alone in operational delivery. So thinking about the capacity and the care associations as a way of contributing to that capacity, I think is important. And 10 out of 10 for the Michelle, the work that you've done, in my view, on bringing the care associations together in West Yorkshire to have a way of having a conversation at you know, the level that the West Yorkshire ICB is at and the other ICBs in that area, and having a regional conversation. And the reason that's important, Nardra and colleagues, is the other thing I've learned is local labour markets are very different. The labour market in West Yorkshire is very different than the labour market, Les, down in the southeast of England where you operate and where I live. And actually, they might need different, in fact, not they might need different solutions. They do need different solutions if you're going to secure that workforce, it strikes me. So I think let's be clear what we can do locally, what we can do at a system level, what we can do regionally, and what we can do nationally. Nada, thank you.
Thank you so much, David. Thank you, and thank you, everyone. Really appreciate everybody's time, and those reflections are just spot on, as always, David. Thank you very much. All that is left for us to do now is to refer you to the slide and contact us. We'll try and get back to you if there's anything that's been left unsaid. Thank you very much, and join us again on the 22nd of March. Thank you. Bye.